Perfect. So I'm just going to jump into it. So Juan, tell me about the program that you're looking to start, because I've heard little bits and pieces, but I want to understand exactly what you're doing. So kind of first, actually, let's go back a step. Tell me about you. You're a physical therapist. Kind of where did you go to school? What got you into physical therapy? Tell me a little bit about yourself first.
So I've been a physical therapist 11 years. I graduated from New York Institute of Technology in Long Island. Prior to that, I was a student athlete. I played volleyball at the University of Montevallo, and I competed internationally for Barbados's national team, which is where I'm from. I got the opportunity to work as a student athletic trainer in undergrad. Unfortunately, when I started, um, they had stopped grandfathering in people because once upon a time you just needed 800 hours and then you could take the ATC exam. I kind of missed the cutoff because I didn't have enough hours to be grandfathered in. I was a little bit short. So and I wasn't about to change majors. So but I, because of my experience doing that, being an athlete and working as a student trainer, when I went into grad school, I got the opportunity to work under Dean Kent Backus at New York Institute of Technology with the Bears as one of their athletic trainers. So that was
Wow.
a great opportunity being in PT school and doing that as well for the sports teams. Um, so let's see. Since then, I worked in a number of settings, primarily outpatient ortho. And so I've had the opportunity to work with a variety of populations, mostly pretty athletic. I did a lot of pediatric ortho, some early intervention, but then mostly like youth sports, middle, high school sports. I've coached volleyball for several years. I took a little hiatus since I had my own kids. Um, and I also saw a lot of women who were very athletic, but a lot of women who were pregnant and women after they had childbirth, after they had their children. Worked next to a trauma surgeon, which was pretty interesting at one point, who was a pretty big referral source. And so I would also get a lot of women who had motor vehicle accidents. They were coming in with pelvic fractures, different things like that. And they were having pelvic issues too, but obviously for other reasons. Um, and so fast forward a little bit, I had my own kids. So then life kind of changed. I couldn't do the hustle and bustle of the outpatient clinic anymore. Um, and so I switched to working in the hospital, and I PRN'd over the years in the hospital setting, inpatient acute rehab, and then the inpatient. But I floated to the mother baby floor and worked with high risk pregnancy, a lot of women, before birth and then again after birth. And so I kept being intrigued by this population. Then I had my second child, and that's when I had my own pelvic floor issues. And so that's kind of what gave me that even greater push, because what I was hearing from a lot of the women in moms groups that I was with my daughter and then with my son, women were having all these concerns, but it was kind of just brushed off. And you'd hear other moms say, "Oh, that's normal. That happened to me too. You'll be fine." And meanwhile, I'm going, no, it's not normal. Like, who told you this? Like, what, since when is, peeing on yourself normal? Or, you go back to working out and you're trying to jump rope or do jump boxes or whatever have you, and you're leaking and, just things like that. And I started to get very frustrated. I took several continuing education courses in obstetrics and then in pelvic health as well. And so I'm just like, you know what, I'm here to help. And that's the reason why I became a PT, because I loved working with people. I wanted to help, but I really, especially for this population, because now that we've got all this technology, there's so much information out there, but it's almost like information overload, and people don't know where to go. They don't know where to turn. They don't know who's a credible source, who they should go to, what's going to work, what's not going to work. And like I tell most people, even my own clients, I always tell them, if I can't help you, I will for sure find somebody who can. My
Sure.
job is to help you. Whether helping you means me physically helping you or me being a resource for you to get you to the person who can best help you, that's what my job is. And so that's why I'm here, and that's what my plans are.
And I mean, you touched on something so important, I think, that's overlooked is normal. What is normal? The new normal. Normal isn't always what's common. And so, like you said, I mean, no, that kind of leakage, lack of bladder control, that's not normal, although it may be commonly, accepted but overlooked. And so, even for myself, with no experience in pelvic health, pelvic floor, um, I see those kinds of things, and I just think
Mhm.
to myself, yeah, like I can remember listening to a lecture on YouTube a while back. This wasn't pelvic floor related, but
Right.
the researcher was talking about waking up 2 or 3 times in the night to go to the bathroom. And she
Mhm.
was saying that that's not normal. Although it's common, that's not normal. You should be able to go to sleep and control your bladder through the night, waking up rested. And
Yeah.
but everybody you talk to as a clinician treating patients day to day, my patients are always telling me, my first question is, how well do you sleep? And their response is, well, aside from getting up 2 or 3 times to use the bathroom, I sleep okay or poorly, or. So yeah, I think we accept common as normal, although it's not, and certainly it's not optimal. So
No.
now tell me a little bit about this group. So what are your plans? What are you thinking of doing? Because I think this is a tremendous idea.
So my plan was to have a group of individuals, group of women who were having issues with leaking. Um, Preferably women who don't have other pre-existing conditions. So for example, they don't have diabetes, which is a systemic condition and can affect bladder function, or even let's say they had neurological compromise, which again may affect their bladder function. So those necessarily wouldn't be ideal patients because they may definitely need more hands-on intervention.
So let
What
me
I would
ask
like,
you, let me bump in for
okay,
people who are listening who don't know what that means, neurological compromise. What would that be an example of?
so they don't have proper bowel and bladder control. Their bowels and bladders aren't functioning optimally as they should. They don't have the control over those organs like they should, because
Okay.
the neurological function that relay between the brain and those organs is somehow not as effective as it should be. Um, so with these women, what I would like to do is, from a virtual standpoint, be able to administer a exercise program and some education to them over a period of about 6 to 8 weeks. They'd like to start off with a smaller group of women because I'd like it to be more intimate and more involved, so I can also dedicate the time to them. Um, Not only to help those people, because again, my goal is to be able to help as many people as I can, but also, there's so many other therapists out there that I think, we feel limited as pelvic health therapists. We want to help everybody. I mean, therapists in general want to help everybody, but pelvic health therapists, because there are not as many of us. And it's
Sure.
like, well, how do we help all these people? Like, we only got two hands and we're located here, and it's like, but we have this gem in technology that I feel we can put to use. Now, certainly it wouldn't work for everybody. If a patient is coming in and their primary complaint is pain, I probably want to get my hands on them and have an actual physical assessment, because there may be things going on that I definitely need to see and be aware of. But certainly there are a lot of things that we could tease out, even in a setting like this where, it's virtual, um, and be able to add some support and educate and be able to help alleviate some of the symptoms, or most, if not all, of the symptoms that they're having. And I think we owe it not to ourselves to help them, but definitely to the patients to be able to help them and offer them those resources.
And really, I mean, as an outsider looking in, listening to this whole idea and concept, I would imagine one of the biggest benefits is some of the intimidation factor goes down.
Hmm.
I just think, it has to be so intimidating to be a person sitting at home right now dealing with these issues and thinking, well, I don't want to go see somebody and talk to somebody, and they're
Right.
going to be all up in my business, and how do I
Hmm.
deal with that? And so at least something like this, it's like there's this barrier. Okay.
Yeah.
I don't even necessarily need to be on camera because
Hmm.
there's still the audio component,
Yeah.
and I can share those stories with other, people dealing with the same challenges and the same situation. And if for any reason at any time I just felt uncomfortable, I just stopped,
Yeah.
But the idea is that I think the intimidation keeps so many women and men out of that, get out of receiving the care they need.
The care they
And I
need.
can think right off the top of my head, two or three women that I've worked with within the last 12 months who were otherwise healthy, doing everything right, trying to improve their dietary intake, cooking at home more, looking for more organic ingredients, really learning and working hard to help both them and their husband, their families. And so within the clinic, the one that stands out most is we were working out. I was taking her through a program and I asked her to jump rope. She couldn't jump rope and she told me, no, I can't do that because of some leakage issues. Her children were all adult children. She hadn't recently given birth or anything, but that was just a limitation she had accepted
Mm-hmm.
for 20 years and didn't even think twice about it, didn't think there was any solution to it. And so me as the clinician, not being involved in pelvic health, I'm thinking, well, I don't know what to do, but now I have an option. So not just the public directly, but even other clinicians like myself who could take this person and say, hey, I've got an amazing resource for you. Let me point you in the right direction. Connect the pieces of the puzzle and then let them go from there. I think there's a lot of avenues to getting the public the care and the information they need. And I think, like you said, the education is just such a huge part of it.
It's a huge component. And going back to what you said, there's a saying in pelvic health, once you're postpartum, you're always postpartum. So it doesn't matter if you just had a baby yesterday or if you had a baby 30 years ago. And what often we tend to find is women will have issues and primarily leaking. And, it's, I do this, I leak. So you know what? I'm not going to do that. A lot of the times they're not brought up to the doctors, or, they bring it up to the doctor at 6 weeks. It's like, okay, well, that's normal. They accept it as being normal and they just go on their merry way. And like, I've had interactions with several people. One in particular kind of broke my heart because she's a physician. She used to be a runner. She had her son and she was leaking, and she kept leaking, so she stopped running. And then she ended up having mesh surgery because she went to one of her colleagues who said, here's what you should do. She ended up with mesh surgery. She tried to run subsequent to that, but she still had the problem. Then she was having heaviness, dealing with some prolapse and whatnot. Um, and so she just stopped altogether. She was like, if this is going to be problematic, I stop. So she just stopped. And we had a conversation about that because for her, it brought about feelings of, increased body awareness. She wasn't feeling good about how she looked or relative to how she was before. And she's a beautiful lady, beautiful woman. Um, and so that's what we usually find. We find a lot of women who will stop doing the things that they love to do, whether it's dancing, sports, running, just going out with friends, because if they try to get up from a chair or they laugh too hard, God forbid, they should have a great time and laugh really hard. Then
Sure.
they're like, oh my God, I think I just leaked on myself. And so it
Uh-huh.
becomes embarrassing. And then we don't think, I don't, we've got to look at therapy and healthcare in general as more than just, you go to see somebody and that's it. Like, there's so many other factors: psychological, social, emotional. You've got these women who can't do what they want to do. Some of them can't go out into public or feel embarrassed to go out into public. So then they start restricting themselves. They start being, less social. Their behavior, their attitudes start to change, and not necessarily through any fault of their own. It's just they're dealing with these issues and no one has ever said, hey, you know what, we can help you. And I think that that's really, really sad, because I was reading some information and it was talking about one of the leading causes of nursing home admits is usually incontinence as well. And when you think, okay, if people have got to get up 2, 3, 4 times in the middle of the night, or, they feel an urge, but they can't control it, by the time they feel the urge, it's like, I gotta go.
Right.
If they're hurrying to go to the bathroom and they're older, so their balance is not as great, or their strength is not as great, now they're at risk of increased falling, you
Yeah.
know? And we don't oftentimes tie in things like falls and all these other things to other issues that they may be having. And bladder health is one of them.
Right. Right. And I mean, I imagine there's a continuum there. You mentioned self-limiting, activity, self-limiting, I think, beliefs, behaviors. Even once you get to the point where, okay, now I've got these strategies, you've empowered the patient, the client, now they know what to do, how to improve. But then there's this 20 years of history holding them back, that now they have to work their way through that. So let me ask you, with this program, do you have any kind of, I know you mentioned 6 to 8 weeks and you're kind of still finalizing details, but do you have any kind of timeline on when you would like to get something like this started?
Ideally, I would like to start around about October, beginning of October. Could be sooner, but beginning of October. I've got some travel going on a little bit in September, but for a period of 6 to 8 weeks, and then trying to work on getting the people who I think would be appropriate for this in there as well. So I'm thinking probably any individuals, again, without pre-existing medical conditions, between the ages of 25 and 50 is pretty big.
Yeah,
I'd like to be able to narrow that down a little bit more, but I don't want to be too exclusive, because the thing is, we've got really active women with no
right.
medical conditions who are like 45 and 50, because 50 is the new 20. So we've got very, very active older women, and we've got younger women who may not have even had children yet. So they may be having their leaking, not on account of, you know, not on account of childbirth, but maybe on account of just poor strategies with regards to their fitness activities and different things of that sort. So I'm still trying to finalize that. And I feel like maybe 30 to 45 might be my sweet spot.
Yeah.
Um, so that's kind of, but again, even if there's an outlier in terms of age, as long as if they're having symptoms, again, with no pre-existing medical conditions, then I definitely would love for them to be a part of the group. Ideally, I would like about 5 individuals, like I said, to work with, so it's very personable. But again, I would like to create a group, a private group where I can have women come together to feel like they're in a safe space, to feel like A, they're being heard, B, they can have any questions answered that they need, and then C, to feel like, okay, you know what, hey, what direction, what course should I take now, with regards to this issue. So
Yeah, I think that's just such a needed community that needs to be built and explored and brought out to the public. So, that being said, whether it be a physical therapist, occupational therapist, somebody in rehab services similar to myself who sees an ideal candidate for your program, or it's somebody in the community, in the general public who watches this interview and video and thinks, yeah, I want to be part of that community, what's going to be the best way for them to reach out to you and start a conversation to see where they fall?
I'm always available via Facebook, which most people are on social media. And my Facebook page is JMM Health Solutions. Um, you can also contact me directly via cell at 770-569-3572, or by email at info@jmmhealthsolutions.com.
Okay, and so what I'll do is in the show notes after we finish, I'll go ahead and post all of those links below so that anybody who comes across this information, all of that content information will be available to them. But I'm going to wrap it up here because I want to be respectful of your time. Are there any last messages or anything that you'd like to share before we end? And I'm just going to say, again, I think that yes, like you said, technology brings people together. It makes those connections where I would have been sitting in my small little office without any resources available to help the people who need help. But now that I know you, now that I know about this group and this community that's forming, 100%. I mean, I've got resources to help my people who need the information.
Absolutely. I mean, and this group is no obligation. The primary group that I'll be working with, or the first group that I'll be working with, I just want you guys to know this is a gift from me to you. No charge, there's nothing, no strings attached. This is me trying to help people. And I feel like that's a lot of us in therapy in general anyway. I mean, I feel like every day we share information, whether it's with a neighbor or a colleague, somebody in a grocery store. I mean, random people might come up to you, they might see you with a shirt on and say, "What do you do?" Like, "I'm a PT." "Oh, I've got this pain." And, I treated I was volunteering at church a couple weeks ago, and one of my colleagues was there, one of my friends was there, and he was like, "I've got this pain." And I was like, "Come here, let me look at you." And he was like, "No, no, no, we're at church. You don't have to. This is your day off." I'm like, "Can you sit down and let me look at you?" And it was so funny. About 10, 15 minutes, I worked on him. He was like, "I can breathe. It doesn't hurt." I'm like, "Mm-hmm." He's like, "What
Yeah.
do you?" Mm-hmm, mm-hmm, "You're welcome." And but it's like everywhere we go, I feel like, and it brings us joy. I mean, I don't know a therapist that I'm friends with or know in general that would say, "I don't like therapy. I don't like helping people." We love it. Like
Right.
it pumps us up. It fuels us when we help people. So
All right. Well, Joanne, thank you so much for coming on and sharing this message.
absolutely.
I really think it's going to reach quite a few people, and especially if our professional group and peers get on board and share it, I think we'll get to the people who need it. So hang on just a second. I'm going to wrap up this recording, and then we'll talk.
Okay.